wondered why chronic kidney disease is prevalent in older adults than in children? Or why is it that growth and development is affected for patient who suffers from renal failure? What are the teaching and learning principles that we can impart to our patient who have this kind of health challenge? Why do I ask you this? Because our team's objective for this presentation is to give you an overview management of renal failure in relation to delirium and depression. So for today's presentation, we will have first the introduction, like what is renal failure, what is delirium, what is depression, and then we will move on to the discussion of the Langara's decision-making framework. We will talk to you about what are the nursing areas of concerns, what are the nursing interventions that we can give to our patients. And lastly, we will have a Kahoot game just for fun and just to determine also if you truly understand what we are presenting to you this afternoon. So, let's begin. When we talk about renal failure, there are two types. One is the acute renal failure and two is the chronic renal failure. When we speak about acute renal failure, it is a syndrome in which the glomerular filtration is declined abruptly, like hours or days, and it's usually reversible. And when we speak about chronic renal failure, it means that there is a persistent impairment of kidney function. In other words, that the serum creatinine levels is elevated for more than 3 months and there's a progressive loss of kidney function, thus it needs renal dialysis or renal transplant. What is delirium? Delirium is a common clinical syndrome characterized by inattention and acute cognitive dysfunction. What is depression? Depression is a common but a serious mood disorder. It causes severe symptoms that affects how the person feel, think, or even their daily life activities such as sleeping, eating, or even working. To be diagnosed with depression, the symptoms must be present for at least 2 weeks.
I'm going to talk about incidence and prevalence rate. In the CKD patients who have problems with depression, females have a higher risk of developing depression compared to males. The percentages are females 86% and males 57%. Moreover, the stages of CKD don't matter to the depression severity. The relationship between depression and CKD is still uncertain, but patients who are struggling with renal failure are at higher risk of depression. The next table compares the prevalence rate of CKD with major depressive disorders, MDD. Patients who are on dialysis are 20 to 30% likely to have mental disease, and non-dialysis patients are 7 to 47%. Why are CKD patients at a much higher risk of depression? According to the BC Renal, there are mainly 6 points. The first cause is disease-related, such as comorbidities, pain, and discomfort. The second cause is related to medications, and biological reasons are anemia, uremia, and inflammation. Moreover, psychological reasons are also related to this. Social causes include such as changing relationship with friends and families, or retirement, changing social rules, and intimacy sex. Finally, change their lifestyle as well. At some point, around 50% of CKD patients experience mild, moderate, or serious depression or any mood disorders.
In the Langara decision-making framework, the first step is assessment. We can review their medical record to understand the patient's present conditions, like diagnosis or medications, and past medical history before meeting with them for assessment. For patients with renal failure, too much sodium in the body can cause edema, hypertension, and less urine. High urea and creatinine levels can cause nausea, itchy skin, and delirium because it affects the brain. High potassium can bring bone pain. Less erythropoietin from the kidneys causes fatigue due to anemia, and hormone changes may make patients feel depressed. We can also check their medications to see if symptoms are still there or if they're having side effects. For example, if patients take haloperidol for delirium, we check if the delirium is still there or if they are dealing with hypotension or dry mouth as side effects. Risk factors include chronic disease, low socioeconomic status, older age, heavy weight, smoking, and family history. When we talk to patients, we observe and listen to them. Once we have a knowledge base to understand their possible symptoms and syndrome, our assessment involves critical thinking competence. For example, if a patient has delirium, we think about whether lack of sunlight could make it worse. Similarly, with depressed patients, we pay attention to how they act without speaking, using our own experience to understand them better. So, to assess symptoms and syndromes with renal failure related to delirium and depression, we need to think, we need to consider different things and different aspects.
There are many contributory factors that affect the growth and development of patient who suffers from chronic kidney disease. And one of it is the nutritional status. Patient who has chronic kidney disease suffers from malnutrition, and because of uremic toxicity, it leads to growth failure. The second one is the metabolic acidosis. So if there is really fluid and electrolyte imbalances that happening in the body, there is an impaired function of growth plate cartilage. The third one is the anemia. If it is very severe, it can impair the growth and development. And lastly, the long-term steroid therapy. It affects by depressing the growth hormone secretion, interfering with cartilage metabolism, and bone formation.
When it comes to diagnosing delirium, there are few handy tools that the healthcare professionals use. One of them is the 4AT, which stands for alertness, abbreviated mental test for attention and acute change. These are the 4 items. If a patient scores higher than 4, it indicates that delirium is likely. Another tools that they use is CAM, which is confusion assessment method. It also assesses 4 features. So it checks for onset mental status, inattention, altered LOC, that's level of consciousness, and disorganized thinking. If at least 2 of these features are present, it also suggests that delirium is likely. Lastly, they use the ICDSC, which stands for Intensive Care Delirium Screening Checklist. It measures 8 different domains, and each is recorded as a yes or a no. So if a patient scores higher than 4, it also indicates that delirium is likely. These tools are what helps the healthcare professionals to accurately diagnose delirium and also provide the appropriate care that the patient needs.
Diagnosis tests for depression. We have laboratory method and non-laboratory methods. Starting with laboratory method. 1. Dexamethasone suppression test. Dexamethasone suppression test is a test designed earlier for Cushing's syndrome, but further research has proven that this test can also be used in diagnosing of depression. 1 to 2 milligrams of dexamethasone is given to a patient daily during this study. Then when there is positive result in negative feedback of dexamethasone, it can be indicating depression, and further assessment can be carried out for depression. Then we have another method that is called genomic method. This is the study of the genes. In the genes, there is a cells, and there is a marker that is designed for this positive result. When there is positive result to this marker during the study, when the cells of the genes are analyzed, then it can be indicating depression, and further assessment can be carried out for the patient. Then another method is proteomic and metabolic method. This is the study of the proteins in the brain cells and also cerebrospinal fluid. During this study, when there is a positive result in the proteins in the cerebrospinal fluid, the markers are indicated during this test. Thematic biological pathway analysis. This systematic biological pathway analysis analyzes the inflammatory response to autoneural immune system. When there is a positive result to this inflammatory pathway indicating of the neural and the endocrine system, then the immune response towards this analysis can indicate depression, and further assessment can be carried out. This PHQ-9 is used as a structural based analysis. A questionnaire is given to a patient, and the patient will be indicating or giving results according to his or her daily activities, such as the way he interacts with people, the way he copes with his job. Does the patient cope daily to his activities? Then the relationship with people. If the patient is having thoughts such as suicide, then when there is positive result to most of these indicators, then the further assessment can be recommended for diagnosis of depression.
So, before we move on to the nursing care plan where we utilize the Langara decision-making framework, I just want to know how's the learning so far? I hope it's good. And please take note that if you have any questions, just write them down because later on we will have a Q&A, okay? So the first step in the Langara decision-making framework is coming to know, which is also the assessment part. So in general, we will assess the patient for their consciousness, coherence, and orientation. Then we will also check for their overall physical and mental well-being. Then we will also determine if they have any presence of the sensory impairment because our patient is 70 years old above. So most likely they will have a impairment on their visual or hearing. And lastly is their readiness to learn and willingness to follow the interventions that we will set for them. So what is included in the assessment of renal failure? So first on the list is blood tests such as CBC, especially hemoglobin, creatinine, electrolytes, glucose, albumin, urea, and the EGFR or the estimated glomerular filtration rate. For under the microscope, we check for the urinalysis for any presence of albumin and sugar, and also the urine, albumin, and creatinine ratio. And lastly, imaging where we check for the ultrasound, MRI, and CT scan. So what do we consider in patients diagnosed with renal failure in relation to delirium and depression? So we consider their fluid intake, the presence of infection and anemia, if they have any attention or concentration problems, their mood, their sleep quality, their appetite, and if they can perform their activities of daily living. Next is salience. So the following are the nursing diagnoses that we were able to identify in patients diagnosed with renal failure in relation to delirium and depression. First is fluid volume excess.
Next is altered renal tissue perfusion, impaired urinary elimination, altered nutrition less than body weight, self-care deficit, acute confusion, hopelessness, risk for suicide, risk for self-injury, cognitive impairment, and lastly, social isolation. So third step is pattern recognition. Here, we included the nursing areas of concern. Identifying delirium and depression in patients diagnosed with renal failure is quite challenging because many of the symptoms overlaps with the symptoms of renal failure. And sometimes, symptoms of this psychological disorder often go unrecognized. So here are the identified nursing areas of concern. Fluid and electrolyte balance, because as we all know, they need to limit their fluid intake. Next is blood pressure control, because many of the renal failure patients are hypertensive. Next is monitoring and management of renal function, so that we can monitor their prognosis and we can modify the treatment. Next is medication administration and compliance, because patients need to adhere to their medication treatment such as antihypertensive and diuretics. And lastly, dietary modification and nutritional support, because renal failure patients are often advised to change their diet into low salt and low fat. The following are the nursing areas of concern on the psychological disorder identified as delirium and depression. So we need to consider if the patient presents the following: reduced awareness of surrounding, disorientation to reality, combativeness, suicidal ideation, sleep disturbances, missed appointments, lack of focus during appointments, and increased reliance to caregiver. For the planning, these are our goals. First, the patient will maintain fluid and electrolyte balance. Second, the patient will consume the recommended nutritional and caloric intake. Third one is the patient will be free from any infections. And lastly, the patient will identify strategies or interventions on how to avoid reoccurrence of delirium and depression. Fourth part is healing initiatives. Here, we divided it into three parts. First is curative, second is health promotion, and third, illness prevention. So for the curative part, the most important intervention is the patient needs to adhere to the treatment protocol set by the physician, especially if they are undergoing hemodialysis on a weekly basis. Next is monitoring of vital signs, neurological assessment, weight, and fluid intake. Next is religiously take their medication. Like for example, for the renal part is furosemide, and for the psychological part is fluoxetine and haloperidol. And then next is address any sensory impairment, for example, the hearing and the visual impairment, because we will advise them to wear their glasses and hearing aids. And lastly is communicate clearly by avoiding discriminatory tone or using medical jargons. Instead, we use simple and direct sentences and asking short questions. For the health promotion, so we optimize the patient's nutrition, hydration, and continence. We also minimize their confusion by constantly reorienting them. We consider relaxation techniques such as music and massage. We encourage engagement in fun activities with their loved ones or with people that makes them happy. We encourage them in performing their activities of daily living otherwise contraindicated. We also reduce environmental stimuli such as dark rooms or loud noise. We also provide adequate lighting and large font, calendars, and clock. And lastly is we avoid any tripping hazards, especially if they are fragile, weak, or confused. For the illness prevention part, the number one rule is always practice regular hand hygiene to eliminate the bacteria on our hands. Next is avoid populated or crowded areas so that we can prevent getting a virus. And lastly is limit sodium intake and make sure that we only take nutritious foods. And finally, we are down to the last part, which is the praxis or evaluation. So the patient was able to limit the fluid intake into 1 liter per day and was able to maintain the fluid and electrolyte balance. The patient was able to consume the recommended nutritional and caloric intake required by the body. Third is the patient was free from any signs of infection. Fourth is the patient was able to identify the strategies or interventions on how to avoid reoccurrence of delirium and depression. And lastly, the most important, we need to evaluate if they adhere or they follow the treatment protocol or the treatment plan set for them.
So to summarize what we have discussed to you this afternoon, we give you the definition of the key terms associated with the health challenge. Second, we discussed to you the signs and symptoms, incidence and prevalence rate, and also the screening tools. And lastly, we develop a plan of care for individual with renal failure associated with delirium and depression. So I hope you had fun at the same time, learned something from our presentation. So thank you so much, and I hope you have a good day.